All right, good afternoon. I'm John with the Illinois chapter of the AAP, and I thank you for joining us on today's webinar for the ROG Faculty Training. This webinar is sponsored by the Illinois and Chicago Department of Public Health. Today we're joined by Dr. Scott Goldstein from the Northwestern Children's Practice in Chicago. Before we begin, I would like to go over a few housekeeping items. Participant phone lines are muted. This webinar is being recorded. If you have any questions for our speaker during the presentation, please use the text box on the right side of your screen to ask questions, and we will answer them at the end of the webinar. Now I'd like to introduce our speaker, Dr. Scott Goldstein. Dr. Goldstein graduated from Northwestern University and the University of Illinois Medical School. He is a board-certified physician and completed his pediatric training at Hasbro Children's Hospital in Providence, Rhode Island. He is also an instructor of clinical pediatrics at Northwestern University School of Medicine. So please join me in welcoming Dr. Scott Goldstein.
All right, thank you. So we'll get right into it. We have a lot to cover today. So we're going to talk about all of the childhood and adolescent vaccinations that are currently recommended by the CDC. See if I can just take control of the slides here. Yeah. Hold on one sec. Sorry, we're just having a little.
Oh.
Not seeing them on my screen.
Do you have to pull them back up?
Yeah, I don't see them here.
Let me see. I might have to switch them for you.
I'll start talking anyway, but so I can start in the first slide. So there are many serious vaccine-preventable diseases still circulating in the United States and globally that can have serious or fatal consequences for children and adolescents. And ensuring that all kids receive the complete series of each recommended vaccines is important for a few reasons. First of all, as healthcare professionals, it's our job to prevent illness in patients whenever possible. Vaccination has the benefit not only of protecting the people who get the vaccine, but it also protects people who might not be able to get it, like babies who might be too young, or adults who might be too old to get vaccines, or anyone who has an immunocompromised condition that prevents them from getting vaccines. These vulnerable groups rely on a well-vaccinated population to stay healthy. There are also less tangible benefits to childhood vaccination. Some vaccine-preventable diseases are acute, but others cause chronic disease, and all of them can cause long-term health complications. The burden of all the illness on the healthcare system is huge. Keeping people healthy can save a significant amount of money, and there's a time and emotional savings to keeping people healthy as well. When anyone, especially a child, gets sick, they're not the only one affected. Family and friends might need to help the sick person with doctor visits, treatment plans, or daily activities that they can't manage alone. There could be an emotional toll on family or caregivers as well, particularly if someone they care about contracts a serious or fatal illness. Let's see where we are here on the slide. Anything there, John?
Can you see the reaching our goals?
I cannot, no.
Nice.
If you want, I can pull it up. I can pull up my copy of it, and if you can show my screen.
Yeah, please.
Okay. Do that. Okay. Do you see that now?
Yeah, I can see yours. It's just not full screen yet.
Okay. I might have the full screen.
There we go.
All right. So this is the complete recommended schedule for children and adolescents up to age 18, put together by the Advisory Committee on Immunization Practices at the CDC. The orange bars represent the optimal timing of administration for each vaccine, but if a child falls behind the schedule or starts late, there are also recommended catch-up periods indicated in green. Purple bars in this chart indicate the recommended age range for certain high-risk groups, while the newly added blue bars represent the age range for non-high-risk groups that can receive the vaccine. We're going to discuss each vaccine and the timing recommendations in greater detail in this module. One thing that as a pediatrician I like to point out is where this schedule comes from. A lot of people parents have this sense that the immunization schedule is made kind of in secret by a group of people from drug companies or something. And the way that it's made is by this Advisory Committee on Immunization Practices, the ACIP, which has, I think, 15 members or so from various scientific fields. There's one member who's just from a public sector. All of their meetings are open to the public, and all the transcripts are available online. So anybody who wants to see how the schedule gets made is welcome to see it. This is the catch-up schedule for any children who may have started immunizations later than recommended or not completed a series. And this table shows the minimum amount of time that's necessary to wait between each dose in a series of immunizations. So what's new in 2017? There's several changes to the ACIP recommended schedule since last year. First, there are minor changes to the layout of the schedule. A new 16-year age column has been added to highlight the need for a meningococcal vaccine booster dose at age 16. And the addition of a blue bar also serves to highlight this recommendation, as well as to indicate that HPV vaccine can be given to children aged 9 to 10 years, even in the absence of a high-risk condition. There are also new or revised recommendations for influenza, HPV, hepatitis B, Haemophilus influenza, pneumococcal vaccine, the meningococcal vaccine, and diphtheria and tetanus, or the DTP vaccine. And we're going to talk about these as they come up. And finally, there's a new informational graphic titled Figure 3. This resource aims to help clarify which vaccines might be indicated for children and adolescents aged 18 or younger based on medical indications. As we move through more detailed information for each vaccine, the new 2017 recommendations will be noted with a bold red font. This is the new Figure 3, which shows vaccines that might be indicated for children and adolescents under age 18 based on medical conditions. The CDC felt it was important to create this figure as a resource for healthcare providers in order to do a few things. First, to demonstrate that most children with medical conditions can and should be vaccinated according to the routine schedule. Secondly, to indicate when a medical condition is a precaution, additional doses might be necessary because the provider should consult the relevant footnotes for additional information. Just briefly to mention this concept of cocooning that I mentioned in the introduction, that babies under 6 months are vulnerable to many of these vaccine-preventable diseases because they're too young to get all their vaccines, and they have higher rates of infection and more serious outcomes for a lot of the diseases that we vaccinated against. Cocooning refers to a way of protecting babies from these harmful diseases. Older kids and adults are the primary way that babies get infected. Whooping cough and influenza are particularly contagious and harmful to babies under 6 months. And all people who may come into contact with the baby, including grandparents, siblings, and caregivers, should be fully vaccinated. This creates a cocoon of protection to help keep the baby safe. So now we're going to go through the vaccines, each vaccine that is given and the disease it protects against in more depth, starting with hepatitis B. There are 3 different types of hepatitis B infection. Acute infection means a new hepatitis B infection, and there may or may not be symptoms with this. An acute infection can also turn into a chronic or long-term infection. Young children are at the highest risk for developing chronic infection, with about 90% of infants and up to half of all children aged 1 to 5 becoming chronically infected. Perinatal infection is the third type. That occurs when an infected mother passes the infection to a newborn baby. Without vaccination, about 40% of babies who are born to hepatitis B infected mothers will develop chronic hepatitis B infection. Hepatitis B is transmitted through contact with infected blood or body fluids when the skin barrier is breached. And it's important to note that hepatitis B cannot be spread through food, water, sharing utensils, breastfeeding, hugging, kissing, hand-holding, coughing, or sneezing. If there are symptoms of hepatitis B, they generally include fever, fatigue, loss of appetite, nausea, abdominal pain, joint pain, and jaundice. But most children under age 5 who get exposed to hepatitis B will not have any symptoms initially, and only about half of those age 5 and older will have any symptoms. That means infection can be even harder to catch in young children. About 1% of people who have acute hepatitis B will die from the acute infection, but that's usually in people over age 60, and there is no treatment for acute infection, just treating symptoms that arise. The symptoms of chronic infection can range from no symptoms to liver disease like cirrhosis and cancer. And again, children under age 10, and especially those under age 1, if they do get hepatitis B, are very likely to get chronic hepatitis B infection. There are 2 single-agent vaccines that protect against just hepatitis B, and 2 other combination vaccines that protect against hepatitis B and other things. There's also something called Twinrix that protect, or the 2 combination ones are Twinrix that protects against hepatitis A and hepatitis B, and Pediarix that protects against diphtheria, tetanus, pertussis, polio, and hepatitis B. There used to be something called Comvax, which protected against Haemophilus influenza type B and hepatitis B, but that is no longer available. It's important to note that any of these vaccines can be used to complete the hepatitis B vaccine series, so you shouldn't delay or stop the series if you can't use the same brand or a vaccine for the whole time. The 2 single are Recombavax and Energex. All of these are given intramuscularly, and the only contraindication is if a patient has a severe allergic reaction to a previous dose of the vaccine. Precautions giving a vaccine are if a patient has a moderate to severe acute illness with or without fever, or if the baby weighs less than 4 pounds. Hepatitis B vaccine is given as 3 doses, usually at birth, and then a second dose at 1 or 2 months of age, and a third dose given at 6 to 18 months of age. And this table gives the specifics of the intervals between doses. It's important to note that only the monovalent vaccines, Recombavax and Energex, can be given at birth. The combination vaccine, Pediarix, is only given after 6 weeks of age, and Twinrix only for adults over age 18. If a child does not follow the schedule, they can still complete on the catch-up schedule, and the catch-up schedule is shown on the slide here. Now we're going to talk about the vaccines that are given at the 2-month visit. The first one we're going to talk about is rotavirus. Rotavirus is virus is most common in infants and young children, although adults can be infected too. Prior to the introduction of the vaccine in 2006, most children in the United States have been infected by age 5. Infection can occur year-round, but at higher rates from December through May. Rotavirus is shed in the feces of an infected person, and it spreads by fecal-oral spread. Can occur from contact with contaminated hands or objects like toys, countertops, food, water. Infected people shed the most viral particles while they're symptomatic, while they're having diarrhea, and for the first few days after they're starting to get better. Infection usually lasts anywhere from a few days to a week, and anyone is susceptible to rotavirus, but children in child care centers are at higher risk. After exposure, symptoms usually develop in about 2 days and include watery diarrhea, vomiting, fever, and abdominal pain. Other symptoms include loss of appetite, and kids can get dehydrated from this, especially if they're really young. The infection is most severe in unvaccinated children aged 3 to 35 months. Before the rotavirus vaccine was introduced, infections were responsible for more than 400,000 doctor's visits, more than 200,000 ER visits, about 70,000 hospitalizations, about 50 deaths every year in kids under age 5 in the United States. The rotavirus vaccine has done a huge amount to prevent hospitalizations in kids. Globally, rotavirus is still a leading cause of severe diarrhea in children, caused almost 500,000 deaths annually. There's no therapy for rotavirus infection. It's just treated with rehydration. And about 1 in 70 kids who gets this will require hospitalization for IV fluid. Also, kids can get infected multiple times with rotavirus. So even if they've had it once before or they've been vaccinated, they can still get infected because prior infection and vaccination do not provide 100% immunity. There are 2 rotavirus vaccines available for use, and they're both given orally. They're both live vaccines. One's called RotaTeq, and one is called RotaRix. They're slightly different in how they're administered and how the RotaRix vaccine has to be reconstituted with a diluent before it can be given. The recommended schedule is similar for both vaccines, though, with the main difference being that RotaTeq requires 3 doses, RotaRix requires 2. And these are generally given at the 2, 4, and 6 months, or the 2 and 4 month checkups. RotaRix. The contraindications to rotavirus vaccine are a severe allergic reaction to a previous dose, severe combined immunodeficiency, or a history of intussusception. And that's something that people, I feel like, don't always know about, that if you have a child who has intussusception, who has had intussusception, they should not get a future rotavirus vaccine. Intussusception is when one part of the intestine slides into an adjacent part, if you've had it, you'll know that you've had it. Precautions for giving the vaccine include moderate to severe acute illness with or without fever, immunodeficiencies other than severe combined immunodeficiency, chronic GI disease, spina bifida, or bladder exstrophy. The new figure 3 provides a nice visual representation of those contraindications. Now moving on, we're going to talk about the diphtheria, tetanus, and pertussis vaccine. There are 2 different types of vaccines we're going to explore. The difference is that one is for kids under age 7, and the other is for children age 7 and older. A helpful way to differentiate between vaccines is that the uppercase letter refers to the full strength dose of vaccine, while the lowercase refers to reduced doses. The children under age 7 receive the full strength of diphtheria, tetanus, and pertussis. Adolescents and adults get the reduced dose of diphtheria and pertussis. The A in the vaccine name refers to acellular pertussis, meaning that the pertussis vaccine component contains only part of the pertussis bacteria. The combination is the vaccine put together is commonly referred to as DTaP. And we're going to talk a little bit about these diseases first. Diphtheria is a bacterial infection caused by Corynebacterium diphtheriae. This travels through the respiratory system, where the bacteria produces a toxin that can be very harmful. The diphtheria in the United States is very, very rare thanks to the vaccine, but it does still present an important global health issue. Diphtheria spreads through respiratory droplets like a common cold. Less commonly, it can spread from a skin lesion of an infected person. It can also be spread on contaminated objects like toys. Complications from diphtheria are very serious, and mortality rates are high, with about 10% of patients who get it dying even with treatment. Children under age 5 can have even higher fatality rates, up to about 20%. Diphtheria used to be a leading cause of illness and death in kids in the United States, but since the introduction of the vaccine in the 1920s, those rates have plummeted. From 2004 to 2008, there were no cases of diphtheria in the United States, although, as I said, it's still a major health issue globally. Tetanus is a bacterial infection caused by Clostridium tetani. The toxin produced by these bacteria can get into a person's central nervous system, including the spinal cord and brain. The bacteria that cause tetanus are present in the environment, soil and dust. The bacteria most commonly enter a person's body through broken skin and get through wounds exposed to saliva, dirt, feces, to things like puncture wounds, burns, crush injuries, and any injury where you could have dead tissue. The most common initial symptom of tetanus includes spasms of the muscle in the jaw, often referred to as lockjaw. Other symptoms include muscle spasms in other parts of the body, difficulty swallowing, seizures. Complications can be very severe, and about 20% of patients with generalized tetanus die even with treatment. It's a medical emergency requiring immediate hospitalization and treatment. Cases of tetanus in the United States have decreased by about 95% since reporting began in 1947, mainly due to immunization. Now cases are most commonly found in adults who have not received their booster. So diphtheria and tetanus are very uncommon. Whooping cough, or pertussis, is much more common. Pertussis is a bacterial infection caused by Bordetella pertussis. It's another toxin-producing bacteria, and the children under age 1 experience the highest incidence of pertussis of any age group. They're also most at risk for complications. Children aged 7 to 10 experience the second highest rate of infection. Pertussis itself has 3 stages to the illness. The first is called the catarrhal stage, usually lasts 7 to 10 days. This is just usually mild respiratory symptoms. This is followed by something called the paroxysmal stage, where people have severe rapid fits of coughing, followed by the characteristic whooping noise that accompanies the inhalation of air. It's important to note the whoop is not always present in kids or teenagers, but pertussis still needs to be kept in mind in the differential diagnosis of anybody with a chronic cough. This paroxysmal stage usually lasts for anywhere from 1 to 6 weeks, and the final stage is called the convalescent stage, and this is when recovery begins. The cough gets less in frequency and severity, but it can continue for another 2 to 6 weeks after the paroxysmal stage. Pertussis is also sometimes referred to as the 100 days cough. Infants with pertussis, instead of having coughing, may just have apnea, where they stop breathing. But it's particularly important to diagnose whooping cough in this population because they're most at risk for severe complications. About half of infected infants under age 1 will need to be hospitalized. Pertussis is very contagious and spreads through respiratory droplets, like through coughing or sneezing. About 1% of hospitalized babies who have pertussis will actually die from it. It's important to start treatment as early as possible, particularly in young children. And its treatment is with usually just with a course of antibiotics. The DTaP vaccine is a 5-dose series for kids under age 7. There are several brands. All of them are combination vaccines against diphtheria, tetanus, and pertussis. But there are other ones like Pentacell that also protects against Haemophilus influenza and polio. Pediarix protects against hepatitis B. There are another 2 called Kinrix and Quadricell that can be used as the 5th dose, which is given to kids aged 4 to 6 years old. These protect against polio as well as DTaP. The recommended schedule is to give it 2, 4, 6 months, a 4th dose at 15 to 18 months, and the 5th dose between 4 and 6 years. You can refer to the slide here for the catch-up schedule. There is new guidance this year from the ACIP if a 4th dose is inadvertently given too early, which is that if the 4th dose was given at least 4 months after the 3rd dose, and the child is 12 months or older, you do not need to repeat the 4th dose. If a child does not complete the vaccine series by age 7, they have to complete it with the Tdap vaccine, which we're going to discuss in the next slide. The Tdap and TD vaccines are a continuation of protection for adolescents and adults over age 7. They're given in addition to the DTaP series we just talked about and can be used to help catch up older children who aren't fully immunized. Tdap vaccines are only for use in children aged 10 and older and have the trade names Adacel and Boostrix. The TD vaccines are for use in children aged 7 and older, and there are 3 types. They're called Tenavac, one called DT generic, and TG generic. It is recommended that children receive a Tdap dose between the age of 11 and 18, so it's preferred to do this at around 11 or 12. TD booster shots need to be given to all adults every 10 years or as needed in case of exposure events. If an adolescent does not receive Tdap between 11 and 18, they should receive it as soon as possible at any age. This Tdap dose can replace one of the 10-year TD boosters. If a child did not complete the DTaP series by age 7, they're not fully protected and should complete the series according to the catch-up schedule. The catch-up schedules need to be tailored to individually tailored based on vaccine history, but it's preferred that the first catch-up dose be Tdap. The remaining doses, if needed, can be TD. If a dose of DTaP is inadvertently given during the catch-up when the child is 7 to 10 years, this can still be counted as a catch-up dose. It can also replace the regularly scheduled adolescent Tdap dose. The Immunization Action Coalition makes a table that summarizes all the DTaP, Tdap, and TD vaccine timing recommendations and is an excellent resource and is referenced on this slide. Tdap vaccine is particularly important for pregnant women. They should be vaccinated at each pregnancy, preferably at 27 to 36 weeks. For 2017, the ACIP recommends vaccinating as early as possible during this window because data shows that vaccinating earlier in the 27 to 36 week period will maximize passive antibody transfers to the infant and help provide better protection for the baby. Okay, moving on, we're going to talk about Haemophilus influenza type B, or HIB. There are 6 types of Haemophilus influenza, types A through F, and there are some other non-identifiable types, but the vaccine only protects against Haemophilus influenza type B. This is a bacteria that typically remains in people's nose or throat and doesn't cause any symptoms, but it can move to other parts of the body and cause more serious infections. The most common types of invasive infection are pneumonia, bacteremia, and meningitis. Since the introduction of the vaccine in 1990, Haemophilus influenza type B has decreased dramatically. However, children under age 5 still experience the highest rate of infection in the United States. The children at highest risk of infection are infants too young to finish the series and under-immunized children. Haemophilus influenza type B is transmitted directly from person to person or spread via direct contact through respiratory droplets from coughing or sneezing. Prior to the introduction of the vaccine, 20,000 children under age 5 had invasive infections from this every year, and 1,000 of those died. There's significantly less HIB infections in kids now, but most invasive infections still require hospitalization. Up to 20% of HIB meningitis, patients who get HIB meningitis will have neurologic sequelae from that, including deafness, seizure disorders. And about 5% of kids who get Haemophilus influenza type B meningitis will die. As I said, the vaccine was introduced in 1990, and the incidence of severe infection has decreased by 99% since then. There are several types of vaccine available. There's some just with HIB and some that are combination vaccines. ACT-HIB, PEDVAX-HIB, and Hiberix protect only against HIB, whereas in previous years, the ACIP had recommended using Hiberix only as a booster dose. It can now be used in the primary vaccine series. Menhibrix and Penticell are the available combination vaccines. And as I mentioned before, Comvax is no longer available. In terms of how to do the schedule, the best thing is to refer to the slide, and the catch-up schedule for HIB is very complex. And I don't think anybody can remember it without looking at an algorithm for it. Certain groups of kids are at high risk of HIB infection and have special recommendations. Particularly immunocompromised kids are at high risk for HIB infection, like kids undergoing chemotherapy, those with asplenia, HIV, or immunoglobulin deficiency. Children aged 12 to 59 months who are at increased risk for HIB and have had no or 1 dose of vaccine prior to age 12 months should receive 2 more doses 8 weeks apart. And this is another one where you kind of have to look. If you ever see a patient who you're not sure what to do with their HIB vaccine, it's best to refer to a table, because I don't think anybody could actually remember the specifics of it. So I'm going to move on from HIB to next vaccine that's usually given at 2-month visit is for Streptococcus pneumonia, called the pneumococcal disease. There are 2 pneumococcal vaccines to protect against pneumococcal disease. Pneumococcal disease is a bacterial infection caused by Streptococcus pneumonia. Pneumococci can cause many types of infection and are the most common cause of bacteremia, pneumonia, meningitis, and middle ear infection in young children. Pneumococci cause invasive disease when they travel to sites of the body that are normally sterile, like the blood, lungs, or brain. Invasive pneumococcal disease is a nationally notifiable disease. Children at high risk of infection include those younger than age 2, those in group care, those with sickle cell anemia, HIV, chronic heart and lung conditions, those with cochlear implants, and those with cerebrospinal fluid leaks. Pneumococci are typically found in the respiratory tract of children and adults, with about up to half of school-age children being asymptomatic carriers of Streptococcus pneumonia. It's unclear why they don't cause disease in all carriers, but this is the reservoir from which the bacteria can spread to others and cause disease. They spread, like most of these diseases, by respiratory secretions, coughing, sneezing, also in saliva. Rates of disease increase in the winter and early spring, and the symptoms of the most common form can range from fever and chills, ear pain, to less commonly severe forms of disease. Of children under age 5 who contract pneumococcal bacteremia, 1% will die, and of those who get meningitis, about 10% will die. Pneumococcal disease is treated with antibiotics, but there's been an increase in antibiotic-resistant strains. In about 30% of cases of pneumococcal disease, Bacteria is resistant to at least one type of antibiotic normally used in treatment. So as I said, there are two types of pneumococcal vaccine. The PCV13 vaccine protects against 13 different strains of pneumococci. It's usually given as a 4-dose series, 2, 4, and 6 months, and then the 4th dose between 12 and 15 months. The 23-valent pneumococcal vaccine is only given to children aged 2 and older who have certain underlying conditions that put them at high risk for pneumococcal infection. The table at the bottom of this slide outlines exactly which underlying conditions require the 23-valent vaccine and whether 1 or 2 doses is needed. As with most of these, the catch-up schedule is complex and needs to be individualized, taking into account patients' age, vaccine history, and underlying medical conditions. It's given intramuscularly. The 13-valent is given intramuscularly. The 23-valent can be given subcutaneously or intramuscularly. And this slide reviews how to store the vaccine, as well as the precautions and contraindications. Now we're going to talk about polio. We're going to talk about the inactivated polio vaccine, which is the polio shot. There used to be an oral poliovirus vaccine, but it hasn't been used in this country since 2000. So we're not going to talk about that. Polio vaccine obviously protects against poliomyelitis. This is a disease caused by the poliovirus, which is no longer endemic in the United States, but is still active in other countries and can easily be imported by a global traveler. In 2014, 10 countries had circulating poliovirus. The key to eradicating polio in the United States was nearly universal vaccine rate. Routine vaccine is critical to maintain the success of the United States. The poliovirus itself is highly contagious and transmitted via the fecal-oral route. It's shed in an infected person's feces, so contact with feces or contaminated objects can affect another person. Less commonly, it can be transmitted through the respiratory route. Poliovirus is most common in infants and young children, but about 3/4 of people infected with polio will not have any symptoms. Even if they don't have symptoms, though, they can transmit the virus and infect others. The other quarter will have flu-like symptoms that usually last for a few days, and then a smaller number of those people will have much more severe complications. About 4% will experience meningitis, and about 1% will have paralysis or weakness in their limbs. Paralysis is the most serious complication of polio because it can lead to permanent disability and death. Up to 10% of people who have paralysis will die because of paralysis of the respiratory muscles. The iron lung machine that's commonly associated with polio is built to assist with breathing in paralyzed patients. Even if an infected person does not have any symptoms early in the infection, it's possible to experience muscle pain, weakness, or paralysis up to 40 years later as an adult. This is called post-polio syndrome. That is very uncommon. The polio vaccine is given as a 4-dose series. There is a single-agent polio vaccine, and then there are other combination ones we talked about, the Pediarix, Pentacell, Kinrix, and Quadricell vaccine. The recommended schedule for polio is to be given as 4 doses, 2, 4, and 6 months. 2 months, 4 months. The 3rd dose is given 6 to 18 months, and a 4th dose given from 4 to 6 years. The 1st dose can be given as early as 6 weeks, but it's not necessary to move the series up unless there's a reason such as travel to a country where polio is endemic. If a child needs to catch up on this series, it's necessary to have a minimum of 4 weeks between the 1st and 2nd and 3rd dose, and a minimum of 6 months between the 3rd and 4th dose. All of these are given intramuscularly or subcutaneously. There is new guidance regarding the assessment of poliovirus vaccine status in kids who have gotten oral polio vaccine outside of the United States. And we still see that kids who move to this country and have oral polio on their vaccine schedule when they come here. So, if both the oral and inactivated polio vaccine were administered as part of a vaccine series, then the total number of doses needed to complete the series is the same as that recommended for the U.S. inactivated polio schedule. A minimum interval of 4 weeks should separate the doses in the series, with the final dose administered on or after the 4th birthday and at least 6 months after the previous dose. If only oral polio is administered and all doses were given before 4 years of age, 1 dose of the shot should be given at 4 years or older and at least 6 months after the last oral dose. This 6-month period is a change from the current footnote, which indicates the period is 4 weeks after the last oral dose. Only trivalent oral polio counts towards the United States vaccine requirement. trivalent oral polio was used for routine polio vaccine in all oral polio using countries until April 2016. And there's a link there to get, if you only have a vaccine schedule that just says OPV and doesn't say trivalent OPV, you can link to the CDC's recommendation on how to handle that. Next, we're going to talk about influenza, something hopefully we'll start to see less of over the next few weeks. The annual influenza vaccine protects against the influenza viruses circulating during every season. These viruses cause a respiratory infection that comes on suddenly and can be mild or severe, sometimes results in hospitalization or death. There are 3 types of influenza virus, A, B, and C. Human influenza A and B viruses cause seasonal epidemics nearly every winter in the United States. Influenza A causes moderate to severe illness in all age groups and can infect humans and some animals like birds and pigs. Influenza B typically causes milder infections that primarily affect children and can only infect humans. Influenza C infections cause a mild respiratory illness and are not thought to cause epidemics. Every year, an estimated 5 to 20% of the U.S. population is infected with influenza. Influenza illnesses can occur across all age groups, but young children have the highest rates of illness. Influenza virus spreads via respiratory droplets that can be released when a person sneezes, coughs, or is talking, then gets into the respiratory tract of a non-infected person and can cause disease. It's also possible to get infected from touching objects contaminated with the virus. The flu season can go from October to May, with the peak activity usually occurring from December to February. Symptoms include fever, chills, cough, sore throat, stuffy nose, muscle aches, fatigue. Vomiting and diarrhea are also sometimes seen. Most people take a week or 2 to recover, but some will get more severe complications, especially the very young or elderly, those who are pregnant or of chronic medical conditions. Complications include pneumonia, worsening of chronic illnesses, worsening of asthma. And children with neurologic disorders also experience high rates of severe complications and death. In the last flu season, there were about 30 hospitalizations per 100,000 people. The highest rates of influenza hospitalization occur among people aged 65 and older. The second highest rate is kids aged 0 to 4. Since 2004, the total number of influenza-associated pediatric deaths has ranged from anywhere from 30 to about 200 per season, with about 75 deaths last season. Influenza can be treated with antiviral drugs and with supportive care. Picture here shows a still of the respiratory droplets that are released when someone sneezes. And the photo on the right shows an emergency hospital set up to deal with the huge number of people who were sick during the 1918 flu pandemic. The new flu vaccines are created every year in an effort to best protect against viral strains circulating in the flu season. In previous years, there were 2 main types of vaccines: inactivated influenza vaccine and live attenuated influenza vaccine. The inactivated vaccine, or IIV, was previously called the trivalent vaccine. This is the flu shot. The IIV abbreviation is usually followed by a number that shows how many strains it protects against, so 3 or 4 strains. There are a few different inactivated influenza vaccine options on the market, other than the standard vaccine. There's recombinant influenza vaccine that's made with recombinant DNA and has the trade name Flublok. Cell culture vaccine called Flucelvax, and there's also a high-dose trivalent vaccine called Fluzone High Dose. The new recommendation from the ACIP states that live attenuated influenza vaccine should not be used during the current flu season. The reason for this is due to the fact that newly available vaccine effectiveness study from the CDC shows that the nasal spray vaccine, the live vaccine, had poor or relatively lower effectiveness compared with the inactivated vaccine, or the shot, from 2013 to 16. This season, it was not used. I'm not sure what the status is going to be for next year, although I know that the nasal spray is available to order now. So presumably there's a chance it will be back next year. In this presentation, we're just going to talk about the vaccines available for the pediatric population. There's a table on here that shows the slide here that shows the vaccine name, manufacturer, the mercury and ovalbumin content, the indicated age range, and the route of administration. The U.S. has a universal recommendation that anyone aged 6 months or older should be routinely vaccinated against influenza unless medically contraindicated. but there are very few contraindications. Children between 6 months and 8 years may need 1 or 2 doses of the vaccine, depending on the algorithm diagrams on the slide here. If a child has received 2 or more total doses of trivalent or quadrivalent flu vaccine before July 1st, 2016, they get 1 dose of flu vaccine this season. The 2 doses prior to July 1st, 2016 do not need to be from the same flu season or even consecutive flu season. If they have not received 2 or more doses prior to 2016, or if the history is unknown, and they're 9 years old or younger, they should get 2 doses 4 weeks apart. All the flu vaccines are given intramuscularly and stored refrigerated. They are not given to anyone who has had a severe allergic reaction to the vaccine. Moderate to severe acute illness with or without fever is a precaution, and a history of developing Guillain-Barré within 6 weeks is also within 6 weeks of having a previous dose of flu vaccine is also a precaution for getting the flu vaccine. This slide says that egg protein, people who are allergic to egg protein, is contraindicated to get the flu vaccine, although I think most allergists are saying it's okay to give now if they can tolerate, especially if they can tolerate, kids can tolerate foods with baked eggs in it, they can have the flu vaccine in just a general pediatrician's office. Now we're going to talk about the MMR vaccine, measles, mumps, and rubella. First, just a little bit about what these are. Measles is a highly contagious and deadly childhood illness, or virus. In 2000, measles was declared to be eliminated in the United States, although it's quite common in the rest of the world. An estimated 20 million people are infected annually worldwide. About 150,000 people die every year from measles. Because it's still circulating globally, it's imported into the United States and causes infection. A few years ago, there were about 700 cases of measles in the United States. It's extremely contagious and transmitted from person to person by respiratory droplets that can remain in an airspace for up to 2 hours after a person leaves the room. A person who's infected with measles can infect 9 out of 10 non-infected people they come into contact with. Because it can spread so easily, widespread vaccine is critical to preventing disease in large numbers of people. The first symptoms of measles are fever and the 3 C's, cough, coryza, which is the runny nose, and conjunctivitis. This is followed by white spots in the mouth called Koplik spots and a rash. Measles can lead to severe or fatal complications, including hearing loss, encephalitis, brain damage, and pneumonia. Certain groups are at higher risk of serious complications, including kids under age 5 and immunocompromised people, as well as adults over age 20 and pregnant women. Mumps is a viral infection that typically causes swelling in the salivary gland. There's been a 99% decrease in cases in mumps in the U.S. since the introduction of the vaccine, but we still do see a fair amount of it. There was just recently a small outbreak in Barrington. The number of cases every year varies in the United States from a few hundred to a few thousand. In 2016, there were over 5,000 cases in the United States. Mumps is very contagious and can be spread by respiratory droplets, saliva, by sharing cups, utensils, by contaminated objects touched by an infected person. Not everybody who gets mumps will have symptoms, but in those who do, they usually appear about 2 weeks after infection and include fever, muscle aches, and characteristic puffy cheeks and swollen salivary gland. Most cases recover in a few weeks, but there can be more serious complications that are usually more severe in adults and include inflammation of the testicles or ovaries, encephalitis, meningitis, and death. Rubella, also known as German measles, is another type of viral infection that spreads typical viral way by the respiratory route. Similar to measles, rubella was declared eliminated from the United States in 2004, but is still endemic to many parts of the world. The vaccine is still essential. There are still about 11 cases a year in the United States. About half of people who are infected don't show any symptoms, but the most common symptoms in kids would be a rash that starts on the face, spreads to the rest of the body. The most serious complications occur in pregnant women who get infected. If they're infected early in pregnancy and they're not immune, there's a 20% chance that the baby will have a constellation of birth defects known as congenital rubella syndrome, which is the bad thing to have, and most babies who have that will die from that. Pregnant women cannot receive the MMR vaccine, which is why it's so important to complete the series early in order to provide protection. The vaccine itself is known by the trade name MMR2 and ProQuad. ProQuad protects against varicella as well as MMR. given as the 2-dose subcutaneous series. The first dose is usually between 12 and 15 months, and the second dose between 4 and 6 years. The catch-up schedule is indicated on the slide. Severe allergic reaction to a previous vaccine dose is a contraindication. Other contraindications to MMR are severe immunodeficiency and pregnancy. A common concern you might hear from families is whether the MMR vaccine causes autism. It's important to stress that there is a lot of research showing that the MMR vaccine is safe and does not cause autism. The reason this came up was from a report that was written in the 1990s that on a small number of patients that suggested that there might possibly be a link to the MMR vaccine and autistic symptoms. This report has been completely debunked in many different ways at this point. And there are many well-researched, peer-reviewed articles showing there is no causal link between MMR vaccine and autism. There's a link on the slide here that has a good list of studies that show that. It's important to educate yourself, other providers, and families about the truth regarding vaccine safety. Certainly, there can be adverse reactions to vaccines, but they're critical to protect the public from harmful infectious diseases. And autism is not one of the adverse reactions to vaccines. Now we're going to talk about varicella, which is also chickenpox. Chickenpox is a viral infection that once infected, the virus can kind of hide itself in the nervous system of the body and be reactivated later in life to cause shingles. The vaccine was introduced in 1995. Prior to this, there were 4 million cases a year in the United States of chickenpox with about 150 deaths. Since the vaccine has become available, the number of cases and hospitalizations have decreased by about 90%, and deaths are almost unheard of. Chickenpox itself is extremely contagious, spread by respiratory droplets. Shingles, people with shingles can spread it through contact of the shingle lesion. The initial symptoms of chickenpox are fever, fatigue, loss of appetite, headache. Usually occur a couple days before the characteristic rash appears, which usually starts at the face, neck, and back before spreading to the rest of the body. Itchy, fluid-filled blisters that eventually turn into scabs after about a week. Some groups are at high risk for severe or fatal complications of chickenpox, including infants, adolescents, pregnant women, immunocompromised people. And the most common complication from chickenpox these days is bacterial infection of the skin and soft tissue. The most common complication in adults is pneumonia. More severe complications include dehydration, encephalitis, bleeding problems, sepsis, toxic shock, joint infection, bone infection. There's no treatment medically for it, and it should be reminded that we should not use aspirin in anybody with chickenpox because it can lead to something called Rye syndrome, which is exceedingly uncommon these days too. The 2 doses of the varicella vaccine are about 90% effective at preventing chickenpox. The trade names are Varavax and Proquad. They're both live attenuated virus. The dosages are usually given the first dose 12 to 15 months and the second 4 to 6 years. And the contraindications and precautions are as outlined on the slide. Okay, now we're going to move on to hepatitis A. Hepatitis A causes acute liver infection that's usually self-limiting and doesn't become chronic. There's been a 95% decrease in cases of hepatitis A in the United States since the introduction of vaccine in 1995, but the virus is still circulating and causes about 2,500 cases a year. Some people are at higher risk for being infected, like travelers to countries where it's highly endemic, like Africa and in Asia. Men who have sex with men, injection and non-injection drug users, people with clotting disorders, and people who work with non-human primates are all at increased risk of infection. It's highly contagious and spread through the fecal-oral route or through exposure to contaminated food and water. Symptoms usually begin abruptly, but most kids who are infected will not have any symptoms and can therefore spread it to adults. Most adults who are infected will have symptoms like abdominal pain, vomiting, joint pain, jaundice. These usually last for anywhere from a couple weeks to a couple months, although about 10% of people have relapses for up to 6 months. Most people who get hepatitis A will recover without complications, although it's still a reportable disease to the Department of Health. Goes over that. There are two single-agent vaccines for hepatitis A called Habrix and Vacta. They're both inactivated virus. And then Twinrix, as I mentioned before, is only used for those over 18 attacks against hepatitis B and hepatitis A. Hepatitis A is usually given at 2 doses between 12 and 23 months of age, and there has to be at least 6 months between the 2 doses. Now we're going to wind up with the teenage vaccines. The first is for HPV. HPV vaccines protect adolescents from certain strains of the human papillomavirus. There are over 40 strains of HPV that can infect humans. Some of those strains cause genital warts and cancer. Many of the infections don't have any symptoms and are cleared by the body without anybody realizing they're infected, but some strains will persist in the body to cause more serious disease.
Hey, Dr. Goldstein?
Genital warts are... Yes.
The slides aren't actually, they're not changing right now. It's still stuck on varicella.
Oh, Yeah, mine are on HPV.
There we go.
Okay.
All right, it must have just caught up. Thank you.
No problem. So HPV is incredibly common in the United States. An estimated 79 million people are infected with it, and there are millions of new infections every year. It's a sexually transmitted disease. It's the most common sexually transmitted disease in the United States, and nearly all sexually active people will be infected with at least one strain in their life. An estimated 360,000 people get genital warts from HPV every year. Although infections are usually symptomatic, often people only know they're infected by the appearance of warts or by an abnormal pap smear. HPV directly contributes to the burden of cancer in the United States. So every year, approximately 17,000 women and 9,000 men are affected by cancers caused by HPV. In women, it causes cervical and oropharyngeal cancer. In women, it causes cervical cancer, and in men, it oropharyngeal cancer. HPV is responsible for over 90% of cervical cancer cases. And cervical cancer used to be a leading cause of death in women, but that's improved with the pap smears to catch the disease earlier. But it's still a significant problem. Each year, a total of 11,000 women are diagnosed with cervical cancer, and about 4,500 die from this condition. HPV is also responsible for over 90% of the cases of anal cancer and 70% of vaginal, vulvar, and oropharyngeal cancers, 60% of penile cancers. Decreasing the amount of people who get infected with HPV will obviously have a tremendous positive impact on public health. There's no treatment for the infection itself, though its manifestations can be treated. The vaccine is a very important tool in fighting cancer, so it's important that as a healthcare provider, we make a strong recommendation for fully vaccinating adolescents when they come in. Women and men both benefit from being protected from the genital warts and multiple forms of cancer, though some groups are particularly vulnerable and benefit greatly from vaccine. We know that cervical cancer disproportionately affects women of lower socioeconomic levels who don't have full access to healthcare, and those who are uninsured, as well as recent immigrants. There are 2 vaccines available. There's Gardasil, which is a quadrivalent vaccine that protects against 2 of the strains that are known to cause 70%, or there's Gardasil, there's a Gardasil quadrivalent vaccine that protects against 4 strains, 2 of which cause 70% of cancers, and the other 2 cause 90% of warts. The Gardasil 9 strain protects against 9 strains of HPV, was approved in 2014 and recommended by the ACIP as of March 2015. It protects against the original 4 strains as well as 5 additional ones that are associated with about 14% of HPV-related cancers in females and 4% of HPV-related cancers in males. Both vaccines are used in boys and girls. There was one that used to be available called Cervarix, but that's been removed from the U.S. market. Another big change from this year is that the HPV vaccine can be given as 2 doses instead of 3 doses if it's given under age 15. The series is recommended for boys and girls age 11 or 12, although can be given as early as 9. The second dose is given 6 to 12 months after the first dose. If the vaccine isn't completed at 11 to 12 years, adolescents should begin the series as soon as possible. The number of recommended doses depends on when the series was started and how old somebody is, as shown on the slide here. Few more minutes here. So for children with a history of sexual abuse or assault, the ACIP recommends routine HPV vaccine starting at age 9. And for men who have sex with men, ACIP recommends routine HPV as well as for all males and vaccine through age 26 for those who are not adequately vaccinated previously. For transgender people, ACIP recommends routine HPV vaccine as for all adolescents and vaccine through age 26 for those who are not adequately vaccinated previously. Note that HPV is not recommended during pregnancy, although there's no evidence that it does any harm. If a woman is found to be pregnant after initiating the series, no intervention is necessary. The remaining doses should just be delayed till after pregnancy. Pregnancy testing is not needed prior to HPV vaccine. This slide goes over the storage. And finally, we're going to talk about the vaccines against meningococcal disease. These vaccines protect against meningococcal disease, a bacteria caused by Neisseria meningitis. There are 5 different strains of that, A, B, C, W, and Y. The B, C, and Y strains cause most infections in the United States. Cases of meningococcal disease have been declining since the 90s, but there were about 500 cases in 2013. The highest rates of disease occur in children under age 1 and in adolescents age 16 to 23. Meningococcal disease peaks in January and February, and it's spread through the respiratory route. About 10% of people are carriers of the bacteria in their upper respiratory tract, but they don't get infected, but they can spread it to other people. Meningococcal disease is very serious and can be fatal in a matter of hours. It most commonly manifests as meningococcal meningitis or septicemia, and it's important to quickly recognize the symptoms of meningococcal disease to prevent as much damage as possible. Symptoms typically appear 3 to 7 days after infection and begin with the sudden onset of fever, headache, stiff neck, nausea, vomiting, confusion. Meningococcal meningitis can lead to brain damage and death very quickly. In infants, the symptoms can look different. Infected infants can be irritable, less active, vomiting, not eating well, or having altered reflexes. Meningococcal septicemia can lead to amputations of digits or limbs. Treatment with antibiotics should be started as soon as possible if you suspect meningococcal disease, and must be reported to the Department of Public Health and to the CDC. There are several available meningococcal vaccines that cover all 5 strains, but we're only going to focus on the pediatric vaccines. There are 2 quadrivalent vaccines that protect against the A, C, W, and Y strains. These are called Menactra and Menveo, and are part of the routine vaccine recommendation. Menhibrix is a combination vaccine that protects against the C and Y strains, as well as Haemophilus influenza type B. It's for use only in certain high-risk patients. The routine recommendation is to give 1 dose of Menactra or Menveo at age 11 or 12, then 1 booster at age 16. It's also recommended that any 11 to 18-year-olds with HIV get 2 doses separated by 8 weeks. And finally, it's recommended that children aged 2 months to 18 years who are at higher risk of contracting meningococcal disease follow an altered schedule. The risk groups for this recommendation are kids with anatomic or functional asplenia, complement deficiency, those traveling to areas where the disease is endemic, and those who may have been exposed during an outbreak. The schedule is complex and varies depending on the risk group, age, and current vaccine status, and there's a link on the slide above to tell you how to do that. There are new recommendations this year regarding children of HIV getting the meningococcal vaccine. If a child is under age 2, they should receive either 4 doses of Menveo or 2 doses of Menactra. And if a child is 2 years or older, they should receive 2 doses of Menveo or Menactra 8 to 12 weeks apart. Booster dosing depends on the age a child was when they received the initial vaccine series. If a child does not receive the recommended Menactra or Menveo dose at 11 to 12, they should follow a catch-up schedule. If they receive 1 dose between 13 to 15 years, they should also receive a booster at age 16 with a minimum of 8 weeks between doses. If 1 catch-up dose is given at 16 to 18, then no booster dose is needed. There are also 2 FDA-approved vaccines for the B strain of meningococcus called Bexsero and Trumemba. The vaccine doses are not interchangeable, so you have to stick with 1 type to finish the series. It's recommended that any people aged 10 or older receive the series if they're at high risk of infection with the B strain. The risk groups include children with anatomic or functional asplenia, complement deficiency, those who have been exposed during an outbreak, or those who are traveling to areas where meningococcal disease is epidemic. Bexsero is 2 doses and Trumemba is 3 doses. Adolescents aged 16 to 23 can also be given the B strain series, preferably between age 16 and 18. ACIP considers this a Category B recommendation, which means that the administration of the vaccine for this group is at the discretion of an individual clinician. A new recommendation from the ACIP this year is that adolescents in this category can be given a 2-dose series of Trememba instead of 3. There has to be 6 doses between the 2 doses, the 6 months between the 2 doses. This slide goes over the precautions and the administration of the meningococcal vaccine. And that covers all the vaccines that are given in children and adolescents. Thank you.
Thank you, Dr. Goldstein. I might just give it about a minute or two, and then we'll see if anyone has any questions. Otherwise, we'll just conclude the webinar. Just give us a minute. I might just leave it on your screen for now.
Okay.
All right, well, it looks like we have no questions actually, so that's great. So on behalf of myself and ICAP, we'd like to thank you for joining us on today's webinar. This week you will receive an email with a link to the recording of today's webinar, along with the PDF of the PowerPoint slides. Thank you once again, Dr. Goldstein, for an excellent presentation, and to everyone joining us on today's webinar. We hope that many of you will join us for any of our future webinars throughout the year. Other than that, hope everyone has a great day. Thank you, Dr. Goldstein. Thank you.